So welcome everyone to our very first online session of the Healing Arts Encounters in Art and Medicine of the Berlin University of the Arts and the Charité Universitätsmedizin in collaboration with the International Society for Arts and Medicine. This feels like a throwback to Corona times, but here we are and it works as well. I'm very thrilled about today's session because it will bring in somehow another level of discussion, maybe a bit of a meta level on the topics we've discussed in kind of our previous encounters between medicine or the medical sciences and art or art-related fields. So let me start by introducing tonight's guest. I will start with Dr. Amma Yeboah, and let me also tell you how we met or how I got in touch with you, because last semester, my dear colleague, Professor Dr. Natasha Kelly, who's currently visiting professor here at the Berlin University of the Arts for Cultural Studies and Philosophy, she participated also in the healing arts. It was very much about kind of writing or literature as a healing practice. And it was in conversation with a doctor from the Charité, Adak Pemoradi-Sehuli. And after our conversation, I usually ask the participants, who would you recommend for another session? And then she immediately said, actually, we drove back home together in the car, and she said, actually, Amma Yeboah, but she's in Cologne. And shortly after, I reached out to you, Amma. And I think also thanks to the introduction by Natasha, you agreed to talk to me, and that was kind, and I was very happy. And now you're on board. So Amma is a psychodynamic supervisor and a psychiatrist and psychotherapist, specializing in gender-sensitive psychiatric and psychotherapeutic treatment, and as a lecturer and an adjunct faculty member at actually several universities. Amma focuses on teaching gender-specific and anti-racist medicine, emphasizing intersectional perspectives in medical and psychotherapeutic care. Dr. Amma Yeboah studied human medicine at the Free University of Berlin. You completed a training as a critical whiteness and empowerment trainer at Phoenix. You earned your doctorate at the Charité Universitätsmedizin in Berlin, and you completed certification in psychodynamic supervision and coaching at Inscape International in Cologne. Thank you so much for being with us today from Cologne here online.
Thank you, Lukas.
And Amma is entering in a conversation or in dialogue with Professor Dr. Sabine Koch. And Sabine, I met through actually Lily Martin, who is writing her doctorate under your supervision at the Alanus University. And I think when we started this lecture series last winter semester, she approached me, or she came actually, I think, for the first lecture. And through this, I became aware of the work that's been done at the Alanus University, and she introduced me to you, Sabine. And I'm also very grateful that you are with us today. Professor Dr. Sabine Koch is professor for Empirical Research in Creative Arts Therapies and head of the Research Institute for Creative Arts Therapies at Alanus University. And this institute is it's a research institute in Germany with national and international focus that is dedicated to conducting and promoting research in creative arts therapies, the scientific advancement of theories, methods, and empirical research, as well as the promotion and qualification of academic researchers in this field. Sabine is also a professor for dance and bodily movements in Heidelberg. And this is actually also beautiful because in this series of dialogues and conversations, we've covered now music, we've covered the arts, we've covered architecture and space. Last time, it's actually the first time that we're engaging with dance therapies as well. And I'm very grateful that you found the time. So for those of you that are here for the first time, also a warm welcome to the few people that are actually in persona in the lecture hall at the University of Arts in Berlin. Each of our guests will give us a kind of brief introduction into their practice, into their field of research, their interests, of about 15 minutes. And afterwards, we enter in a conversation. I will ask a few questions. The two participants can ask each other questions, and you, the online and as well the live audience, are very welcome to ask questions as well. This is meant as an open dialogue. So, and that said, again, Sabine and Amma, thank you for being here. I would give the first word to you, Sabine. The virtual stage is yours.
Thank you very much, Lukas, for the introduction and those words that already, told the public and everybody who's listening what I'm doing. So basically, I'm at two sites. I'm in SRH University Heidelberg, where I'm doing the dance. I'm a professor of dance movement therapy, and we have a German program and an international program. I'm very excited about our international program because we get students from all over the world, really, which is super great because of the cultural exchange around their dance practices and their dance backgrounds and the cultural sharing that happens. And I'm also in Bonn, where I do research in all of the creative arts therapies, art therapy, music therapy, dance movement therapy, and drama therapy, poetry therapy. And this is my main employment at the moment at Alanus University, which is a wonderful place to do research at. Thanks for the invitation to the Healing Arts Berlin. It's a pleasure and an honor to speak here today. I would like to introduce a couple of things that we do in the Research Institute. We are doing research in all of the creative arts therapies, as I already said. For art therapy, for example, we have projects in palliative care and in oncology together with the university hospitals in Bonn, Dr. Radbruch and Dr. Schmidtwolf, where we are conducting an RCT in the oncology and also having a project around a mobile service for palliative care patients for home treatment with creative arts therapies. And our research, it's interesting that I'm the first one who has a dance therapy background. So let me move into that direction a bit more. We've been doing research on dance therapy for patients with depression and anxiety, for people with schizophrenia. So this is our main field, usually the mental health area, but we've also been looking into dance therapy for autism, where there are a lot of great successes by just employing the mirroring technique with kids, with young adults, adolescents, with mirroring and movement. And we are more recently looking into neurodegenerative disorders, also collaborating with Dresden, with the DCNE there, on tango therapy for Parkinson patients and also for dementia patients. We also do have groups in our outpatient center in Heidelberg on tango therapy for Parkinson patients. So we're just evaluating the outcomes for that group. And my favorite project at the moment is our dance therapy for refugee women with trauma experiences. We've just finished the third group that we are conducting here, and we've just been looking into the results, and it looks great. I mean, we got very good feedback from them about how they profited and benefited in their view, but it also shows in the numbers. I've just been calculating the last 2 days, and we can actually show that the trauma symptoms are going down, the depression symptoms, the anxiety symptoms, and the stress symptoms. So that is wonderful, and I'm looking forward to write that up and to send that in for publication. I think I still have a little bit of time.
Oh,
Is
yeah.
that-
Yeah,
is that
plenty.
right?
Yeah.
Okay, then I would maybe go into the Tango for Parkinson work and the Tango for Dementia work. So Tango for Parkinson is one of the best researched fields in dance movement therapy. We do have these groups where we also did some research, and the quality of life can be significantly improved by partaking in Tango for Parkinson's. And yeah, it's just great to see how the patients get into the tango dancing where you really focus on the partner. You have to focus on the partner because of the signals, because it's an improvised dance. And then you can just see how they don't focus anymore on the movement, and they're just doing things that they would never do if they would consciously like focus on it, like going backwards, turning around. And so they are really benefiting particularly from tango, because tango has a lot of initiations and stops, and that's what they need to practice, the initiating, and that is what tango allows more than other dances, actually. Yeah, we also had a wonderful project on drama therapy for the children in the Ahrtal and Kreis Euskirchen after the big flooding in 2021, where we sent out 10 drama therapists. Actually, basically, a foundation developed the idea, and they asked us at the RIArT to do the evaluation of that project. And we were able to bring drama therapy to more than 600 children in elementary schools and in kindergartens there. And we're also able to show effects of even though there was no control group, because the foundation said we want to give drama therapy to all of the children who can basically, be reached. So, but also there, the effects were very good. The children's resilience was considerably strengthened by the drama therapy that the 10 drama therapists provided. So maybe I'll leave it there. Maybe on a personal note, just to say that I'm doing capoeira since a couple of years, and I'm loving it. It's an Afro-Brazilian martial art that joins music and movement and free interaction in the Roda. So that's one of my things that I do for myself as a movement practice.
Thank you so much, Sabine, for the kind of quick introductions into the kind of various fields you're engaged in. And maybe we can also learn a little bit more also of the research done at the Institute for Creative Arts Therapies, because it's kind of unique. I was even surprised that such an institute exists. But now to you, Amma. When we had our little kind of first online meetup a few days ago, we realized that your expertise brings in also something completely new to this series, namely the meta level of being a supervisor of art therapists, or even more specifically dance therapist. So like actually we have been focusing on the relationship between the patients and the therapists here, obviously before, but then the art therapists or the medical doctors and the patients. But now you look as a medical professional and a psychiatrist in working with the therapists themselves. So that's another kind of feedback loop that's happening here. However, you will tell us more about this. Stage is yours now, Amma.
Thank you so much, Lukas, also for the invitation and for the very friendly introduction. And Sabine, I'm so looking forward to our dialogue. Very excited also. Yes, so thank you for joining us today, especially the students in the lecture hall. I can see a few. And I'll start by maybe talking a little bit about my clinical practice as a psychiatrist and a psychotherapist. After 13 years of clinical practice, I decided to focus more on education and supervision in the past 5 years. So in the past 5 years, I focus on how clinical structures inform our perception and our interpretation of health and ill health, as well as of well-being and disease. And so basically, since 2019, I've been focusing more on health literacy. And in that sense, really looking at structural competency of healthcare practitioners. And so maybe a little bit from my clinical work, when I was doing clinical work in psychiatry, basically in the ward, I noticed very early, actually, as an intern, that clinical practice in psychiatry and psychotherapy is basically focused on medication. So as an intern, the first and major expertise is to get a sense of really pharmacological therapy, as in seeing medications and their effects, and also, of course, their side effects, but basically really going into diagnostics and looking at which medication can I use for treatment. I did notice, though, that when we had visitation or team meetings, there were multi-professionals in the space. There were art therapists, there were dance therapists sometimes, depending on the ward. There were movement and physiotherapists, but there were also therapists who were doing like horse riding or swimming. So there were a lot of movement therapists in the space. And I noticed that their voices were actually very silent. So for many years, maybe for the first 2 to 3 years, I was not actually aware of what they were doing there. I knew they were doing something, though, because, you know, I knew from the structure and also from the therapy plans for the patients that, you know, I could see on the schedule that there was something, you know, like dance therapy or maybe art therapy, but I was not really sure what exactly was taking place in those spaces. And so later on, as a specialist, I noticed that looking at the work of the art therapist, I could actually modify my medication, and I could see the patients through their eyes to notice what changes were happening when we actually do medication. And so I learned to somehow also collaborate and rely on the perspective of the arts therapist to see what is going on, because patients in consultations, you know, in the hospital is just 5 minutes, maximum 10 minutes. You don't really see much, right? You just see, it's really concerned about symptoms and about histories, but you don't really see how they are creative. You don't see how they are interacting. You don't see how they are moving, and you don't really see how they are progressing over time when we do medical treatment. So in the past years, I focused more on education of medical students. And here I have gender-sensitive medicine at the intersection of race and socioeconomic status. And so my seminars are basically 3 seminars. The first seminar is critical whiteness for medical students. And then I do empowerment and resilience for scientists. These are researchers in the medical field. And then I have a third seminar, which is focused on psychotherapists in trainings. In Germany, we call them PIAs, the Psychotherapeuten in der Ausbildung. And these ones do critical race in psychology and psychotherapy. And so in focusing on the students in the education, I noticed that they had questions concerning structures, because students always have that idea during studies. For me also it was like this, that it is the individual behavior of patients which are actually influencing their health and their health status. And so becoming aware of the fact that also the structures of healthcare and healthcare systems, also the communication with healthcare practitioners, actually have a major influence of how patients are experiencing their health, experiencing their illness, experiencing their disease, and also their healing journey. And so when I focus on healthcare practitioners, here is what I do major at the moment. This is my main focus. Most of my time, 80 to 85% of my work is the psychodynamic supervision of healthcare practitioners. Here I have the physicians, I have the psychotherapists, and I also have the so-called special therapists. And so we call them special therapists in psychiatry and psychotherapy. I have also some teams. And the special therapists are the dance, the movement, the music, and the art therapist. And so it's interesting for me to see the therapists in the multi-professional team and to see them in their own team as special therapists. Why? Because when they are in their team as special therapists, we notice that they are really fighting against structures which are silent in their practice and structures which are actually not able to see their perceptions concerning mental health care and how patients can actually heal. And so they are dealing with very hierarchical structures in the clinical practice where physicians' voice is basically priority. And you can see this during visitations, who is heard, who can speak, and who cannot speak. And even if you speak, who can be heard and who can be, appreciated concerning what they actually perceive in patients' health or illness. And so psychodynamic supervision is focusing on the unconscious processes as it relates to the relational dynamics, conflicts, organizational structures, and organizational culture. And it's really about reflecting on how they can become more effective. Most of the time, special therapists are coming to me with the question, should I stay or should I go, right? Because they are very close to patients and there's much that they have to inform, much that they can see also according to diagnostics and health, but they are not able to really practice their work in clinical settings. And so I'll share my screen and then I show you a little bit of what I do. And so it's the basic of my work with professional health, with healthcare practitioners is really about looking at the global evidence that basically shows us that mental disorders, mental challenges in populations are really strongly socially determined. That means the individual factors are also important and relevant, but it is even more relevant to look at how they are socially embedded in society when dealing with patients with mental health challenges. And so looking at determinants of mental health, I am looking at that with an intersectional lens, an intersectional analysis of structural violence in society, and my main focus is on gender and sex. In German, we have the beautiful word Geschlecht, which actually means both gender and sex, but in the past 5 to 10 years, we are very much using the word gender as social form of Geschlecht. And so looking at gender at the intersection of race and experience of racism in psychodynamic supervision, where I can really focus on how the supervisees are also relating to me. And so looking at that space of reflectivity, of transference and countertransference dynamics, they are able to actually speak up and notice how they are experiencing their own profession in clinical settings. And so to summarize what we actually do is we are looking at the chronic social stressors in the environment, which are actually having effects on the patients that we treat. And we are looking also at how chronic diseases in the sense of metabolic syndromes are having also relevant effects, and how life events, major life events like traumatic experiences, or sometimes it's also divorce, sometimes it's birth, sometimes it's refugee experience, which have effects on patients. And so we are really looking at how the allostatic load is informing patients and how they are individually actually relating to themselves and to others, and how they are behaving in a way that is influencing their health and especially their mental health. So working with mental health professionals, I'm basically looking at their structural competency in medicine, in psychology, and of course, in their various artistic therapists. And so I have a group of dance therapists in supervision, and sometimes I'm also supervising one-on-one, especially when it's about critical race, about whiteness, and therapists feel a sense of, sometimes a sense of guilt, sense of shame in voicing out what it means to experience racist discrimination in clinical settings and being on the side of a perpetrator, something like this. So sometimes there's also that need for private space to speak about their perceptions and how they are experiencing gender at the intersection of race. Yes, so I would stop here, and I hope we can go into dialogue and have some fruitful discussions. Thank you for your attention.
Thank you so much, Amma. This was a lot of input and incredible informations there. I will start, no? And to our online audience and the audience in the lecture hall, again, the principle of philosophy is there's no such thing as a stupid questions. Very much feel free to ask. For the online audience, I have to check with my colleague Jakob. I guess you would have to raise your virtual hand and then you would be unmuted. If this is not the case, Jakob, give me a sign.
I think maybe just start speaking.
Or just start speaking, because they're all silenced.
But I will always stop the recording before when someone starts speaking up, I will turn off the audio in the recording, so you will have to paraphrase the question. And that's also for the physical audience. The mic will be heard in the room and in the WebEx conference, but I will turn off the mic in the recording, so you have to paraphrase.
Okay, good. Thanks for the editorial notes here. But starting with you, I took a few notes while both of you spoke, and I see there's a lot of similarities in what you spoke about, even though coming from different fields, but also almost terminological parallels. And maybe we start with relational dynamics. I think that's something that is at the core of both of your practices. Sabine, you started speaking about kind of the relations that people have, for example, through dance, and kind of you spoke of mirroring. And I think one of your terms of research focus is also kind of interactional resonance. So how do we resonate in interaction? And you, Amma, spoke of transference and I believe counter-transference as being kind of a key element in psychodynamic supervision, also between the patient and the therapist. So there is a similarity that I see, even though they are interpreted in different ways where you're coming from. But did you see the similarity as well? And can you relate or kind of elaborate a little bit more on this notion of relational dynamics and transference and counter-transference, interactional resonance, and how you interpret one another?
Yeah, very happy to, Lukas, but I really have a first response to what Amma said first, and then I go into the relational dynamics, if that's okay. I really think it's so interesting that you're supervising dance therapists, and their question is, should I stay or should I go? Because we know that in the medical system, there's a strong hierarchy, and the simple therapist in a therapy team often feels maybe not seen enough, maybe not known enough in there. So I think there's a big question of appreciation of, in an interdisciplinary team that plays a big role here. And it's very nice to see, Amma, that you having this appreciation for the arts therapies, because you also know them more intimately by this supervisory role. It's always very good to see that we have medical doctors, psychiatrists, psychologists who are having that appreciation of the profession, of the work with the arts, with the healing arts. I wanted to say this first, and then let me go to a brief statement about the relational dynamics. Of course, we work with the relation in creative arts therapies. It's a definition of creative arts therapies that we work through art, in the therapeutic relationship, which distinguishes it also from the arts and therapy, where we may have an artist who comes into, a nursing home and does an art project with the people, but there's not the central role of the therapeutic relation, of course, because also an artist doesn't have a training as a psychotherapist. So, of course, that is a distinguishing factor between the creative arts therapies and the arts in therapy. So we work with that relationship. We work with a relational space in a safe space that we create and an active space that we create. The inactive is very important because we work with all of the arts in an active manner. So we have the people immerse into the arts in that space, and we have this turn into an as if space, into a play space, into a relational space, into a nonverbal communication space, into a generativity, creativity space. And all that is happening because we have people immersed in the arts in this relational space, and that contributes as an important therapeutic factor to the healing process. So just that for now. And as Lukas said, we do this a lot of times also by using mirroring and movement, which is a great technique in order to build the therapeutic relation in the first place. Mirroring not only in movement, but also in music, in art, in drama therapy.
Yeah, thank you. So, Sabine, to come back to your remark concerning physicians and art therapists, or especially when it comes to dance and theater therapies, for me, it was also a learning journey, right? Because I did not really learn this. Although I was working in the clinic for psychiatry, it was sort of like taken for granted that there are multi-professionals who are just not somehow relevant, although they are present, sort of like ambiguous. They are present, but they are also not present because they are not really taken into consideration concerning diagnosis, concerning, if there's improvement in the healing journey. So it was ambiguous for me at first, and I needed really time to understand somehow at the beginning intuitively. It was a question of what are they actually doing here, right? But it's not really spoken of, It's sort of like a silent question. And so that also informed my work of how silence can happen in a space of hierarchy without actually telling individuals or professionals to speak or to be silent. It's just somehow sensing into that focus on medicine, medication, and somehow intuitively knowing that all other sorts of therapy somehow are not, well, maybe they are not irrelevant, but they are not as relevant as medication, right? So that sense of hierarchy in that space actually induces this silencing of your own expertise or your own perception. So this one part of my experience. And the other part of my experience is as I became a specialist, or as I gained more experience in psychiatry, I noticed that actually I don't really know much about the patients, even if I do a lot of history and I do a lot of medication and laboratory tests. There is a certain kind of information that I know as a physician, but really like relating to the patients, there is just very little that I know. Because, the patients also are different versions of themselves, whether they are speaking to the physician, or they're speaking to the nurse, or they're speaking to the arts therapist. So for me, it became very helpful to speak to the various therapists and to see, what did you see? What did you notice? What did you hear? Right? Because that I learned to use that information to also inform my practice and to be more sensitive to the needs of patients. So for me, I learned to appreciate that, in the sense that actually I don't really have much time and I don't have much capacity to know patients as intimately as, for example, movement, dance, artistic, connection can do. And so right now in my practice, looking at when I have a multi-professional team, like a psychiatric team, then I have all the mental health practitioners in one space. And in this space, it becomes very useful to look at relational patterns, which are happening in the organization and which are also repeating themselves within the team and as the team is relating to me as a supervisor, right? So looking at these patterns becomes very helpful for us to actually notice and also reflect on these relational dynamics. And then it gives us also information about the culture, right? The cultural practices in these organizations. And then we notice that it's not only about hierarchy, it's also about how we are trained to perform medicine, how we are trained to understand health and health status, and how we are trained also to see people as people. And so all the psychodynamic supervisory tool is very helpful to look at all these different aspects also of relating and finding meaning and also finding word for that, what the mental health practitioners are actually experiencing.
Beautiful. Thank you, both of you, for these answers. And maybe picking up on what you referred to in the beginning, Sabine, on Amma's work and the kind of should I stay or should I go question, and what you just addressed also again, Amma, the kind of various hierarchies that exist within clinical structures. You spoke about this in the beginning as well. Let's say within the arts, there is a term of institutional critique, and that's kind of a within the arts. There's basically a systemic inquiry into the workings of art institutions. What you do seems to be also institutional critique, but just in the health sector. You spoke of kind of trying to advocate for health literacy or structural competency. This is a structural or institutional critique, also of defining what is actually healthy or what is not healthy, what means healing, and who do we define actually also as sick. This is a topic that has come up here in the previous semester a couple of times, also of like different definitions of what it means to be well or to be healthy, and maybe also from different cultural perspectives. Could you elaborate a little bit more on this?
Yeah, maybe I go for it, Sabine. So I would begin by saying that in the clinical setting, there is no space and no time to actually have this kind of conversation. That's very important because our health care system, I don't know about other systems, I would say in Germany, it's really structured around acute intervention. That means that we have a tool, or we have many tools, but we call it our Bible, right? In psychiatry, like we have one Bible. The first Bible is the ICD-10, right? The International Classification of Diseases, the 10th edition. And so when patients come, what we are actually doing is we are looking at the criteria in our Bible and clustering their symptoms according to whether it's affective disorders, psychotic disorders, like, first of all, they have to gain that category to actually legitimize their access to healthcare. So that's the first Bible. And the second Bible is the pharmacotherapy, right? So to see which medications can we apply and how long and in which dosage. And so our system of mental health care is really very specific, is very acute, and it's really also clearly defined what we do and what we do not do. And so in that fast track environment, we do not really have access to such questions as, oh, how our structures are informing our work. We can only do that when there's conflict. And this is why conflicts are so, for me, so important and so relevant to look at. And so psychiatry and psychotherapy are one of the clinical disciplines which actually receive supervision. And so during supervision, we are bringing a case. And by looking at that case, we are able to gain a little bit of perspective, how we are relating to each other, how we are working in a kind of structure. And so the supervision space becomes a window which could give us permission to actually ask and access these questions. And at the same time, in clinical practice, supervision is rare. It's not very like, spacious in the sense that it's not everything that you can say, right? And so external supervision becomes very, very helpful. And so external supervision is when the supervisor is not attached to the clinic, and healthcare professionals are actually leaving the clinic to visit the supervisor. And so that's in that space, I noticed that it's much easier to actually pose certain questions and to reflect on these questions as well. And it becomes very relevant, especially as I say, the conflicts seem mostly acute, but the conflicts are very, very important, and they are very, I would say it's very helpful to appreciate also conflicts in general, because the conflicts are, if you want, the fuel that we use to actually drive that reflective spaces. So looking at questions concerning how are we maintaining certain structures, we don't really call it critique, because we kind of shrink at the idea or at the word critique, right? Even if I call my seminar Critical Whiteness, it's very seldom that we use the word critique in clinical practice. What we do is we like to use words like reflexive spaces, dialogue, because it's more like inviting also for mental healthcare professionals to come in such spaces. That means we do that, but we wouldn't call it critique.
And Sabine, back to you. What kind of spaces do then art therapies open up that are breaking with these kind of clinical structures?
I would say arts therapies open spaces for the subjective experiences of the clients in a very phenomenological way. They open sensory spaces where we immerse into, materials and actions, and we are bringing the attention to the here and now with the things that we do with the patients and to the sensory experiences. And they are also, in a lot of cases, stimulating interactions among the patients. We mostly work in groups with the patients, and so they provide spaces to share the subjective experiences and the sensory experiences. And maybe just as an example, our work with schizophrenia patients, where we know that medication can do a lot of good in reducing the positive symptoms, but the negative ones are not easily addressed. And just those negative symptoms, the blunted affect, the motor retardation, the social withdrawal, that can all very well be addressed by all of the arts therapies, because they advance, they further, they stimulate expression in any way and interaction, and also, motoric involvement, and stimulate, the application of new movement qualities and sensory qualities. So that's, I think, very important. So the arts open these spaces and possibilities of self-expression, of embodiment in the first place, of impression and concretization of something that is inside of me to the outside, and then communicate that in a symbol or a metaphor, a nonverbal way to the therapist, to give that an outlet other than the word, where we have other therapies, right? And also in a way, bring forth the resources, bring forth the strength that are there in the patients, which is very important in our work. And by that, by having patients discover their strength and their authenticity, which is also another goal in creative arts therapies, also then reduce the stigma, because then hopefully the patients can go into the world with another kind of self-esteem, about their disease, not only as a handicap, but as an asset, you know, as a part, as an integrated part. Hopefully we can also contribute to stigma reduction, as it was also shown in our project. Lily Martin, who did the Pop-Up Institute for reduction of stigma in schizophrenic patients. And that's another project that would be maybe worth to have it on this dialogue series, maybe. Yeah.
Very true. So maybe a pick up on this as my last question before I open up to the audience. So dear audience, online and in persona, again, no shame in the game. Ask any questions. I'll give you one more question time. But you spoke of stigma reduction, or anyway, stigmatization. The topic that also reappeared here quite often with patients, where it seems like the art therapies could offer kind of another exit that's not as stigmatized as, let's say, Amma, you spoke about the lack of supervision or education also for practitioners in the medical field, both the medical practitioners as well as the patients, where it appears sometimes that art therapies, well, shortcut is maybe not the right word for it, but at least it gives a different alternative entry into a field that is maybe that are still very stigmatized. Can you relate to that too?
Definitely, because you see, when we apply our diagnostics and we categorize the symptoms and we more or less label the patients according to their pain or their symptoms, what we do is that, in a way, we erase also some parts of their personality. And this is very relevant, especially in psychiatric patients, who in German we say die Depressive, right? Or die Psychotika in. So by wording and naming the patients according to their diagnosis, in a way, it's an erasure of personality, and at the same time, it's a labeling. And this is how stigma also is somehow, through our practice, more or less, is maintained. And so by actively referring to people with their name and saying with, and understanding that also with this diagnosis, it's just a phase, art and art expression becomes very, very important. Because through that, I'm able to access also my patient and to see that, oh, it's not only about depression, it's also about something else. It could be another theme. It could be also not only creative expression, but also a form of communication. Like the artistic work becomes a communication tool. And so for me, as a psychiatrist, when I work with patients, it's very important and relevant for me, not only in the context of stigmatization, but in the context of understanding who I'm working with, who I'm actually dealing with. I need that, right? And at the same time, I like to notice and appreciate the fact that this is not our usual standardized practice, right? It's not. Because as I said earlier, our fast track way of dealing and working with patients actually hinders this kind of perception, hinders this kind of reflexivity, and also hinders this kind of communicative tool, you know, to actually get to know the patients not only as a diagnosis, but also in their full personality and in their fullness as humans. And so for me, the theme of art therapy, it's very relevant when I do not wish to label patients with diagnosis, right? And for me, it's very important also. I was thinking about this, Sabine, when you talked about your project of working with refugees with trauma and having that kind of door for them to access therapy without first receiving some kind of label without first entering some kind of psychiatric institution, because there are different ways of healing. And that door through psychiatric institutions can be very hurtful for patients, not only because of the stigmatization, but also because of those restrictions through the fast track methodology, through the lack of reflexive spaces, through the the ignorance also of the art therapy, right? I mean, there is a lot of ignorance around that, what it can and what it cannot, and not experiencing the fullness of the methodologies of art therapy. So for me, it's also really, yes, looking at my own practice and being very critical how I'm, distributing with my Bible, right? The diagnosis or not. And I would rather prefer not to do that. I'd rather refer people with mental health challenges immediately to some kind of therapeutic spaces without first needing to, push them through that gateway, right, of going through psychiatric and diagnosis. Yes.
Yeah, anytime that we postpone meaning making, we're actually starting to learn. So it's very important to, postpone that judgment as long as we are able to, about, diagnostic categories and everything else. Yeah, I think, for some of the refugee women, particularly the ones with the lower education, they wouldn't have gone to psychotherapy. They were going to dance therapy, They would maybe go to art therapy if they're, And for others, like the ones with the higher education, they would have gone to psychotherapy, but there's no possibility often because the mental health area for refugees, it's just totally unterversorgt. I don't know how to say that in English. It's very, very difficult to access help in that sector. So we are actually seeing that there's a huge need. People are very traumatized. We have them, if I look at the symptoms, they're all burdened and they're all clinically relevant, depressed and traumatized. There's just very few possibilities. We have a Center for Bias is organizing the Psychosocial Center for Refugees and Torture Victims, Nordbaden, but they have also very limited capacities. So the need is big and there are very, very small possibilities. But let me say on the positive side that the Center for Refugees in Nordbaden has organized that the ministry is actually reimbursing art therapy and reimbursing music therapy and dance therapy. So that's a very good news that there is at least financing for our sector in that area here in Baden-Württemberg.
Thank you. Now I would like to open up the questions to you guys, the audience. Please feel free, and I have to kind of repeat it eventually for the recording, so you can keep it short and sharp. So who dares? Someone always has to break the ice, and then afterwards it's easy. Who's the brave one?
I have a question from the online side.
Wonderful. That's Rosalina. Yeah. You can.
Louis, but yeah.
For the beautiful question. It's a bit silly, but I will repeat it again so it's eventually on the recording. So we received a question from a medical student or professional saying that we spoke a lot about the limitations and shortcomings of the medical system. But now the question was more on a proactive side of things. What are the ways to kind of work maybe within the system or even change the system, both from the perspective of the art therapist as well as the psychiatrist or medical professional?
Yes, thank you so much for this question, because this is a very useful question, since we, as a collective in Germany, of course, have a very well-structured healthcare system. And at the same time, sometimes we have a feeling that we are just complaining. And so I'd like to also look at that, that expression of looking at the shortcomings of the systems. I think that it's really, really relevant to look at the also the very relevant and helpful structures in the system as well, right? Especially in acute situations, you know, it's very, very, very helpful. And so when we look at shortcomings, it's not really looking at the shortcomings as so much as looking at who is able to access the healthcare system, actually, that the perspective of public health. And so when we ask these questions, who is able to access, this is when we see actually that our healthcare systems are structured around masculinity, are structured around whiteness, structured around disabilities, you know, so this is how we see how intersectionality plays a very major role concerning who is able to access. So it's not really about shortcomings, it's really about asking, could we create spaces, could we create structures which allow everybody in Germany to access healthcare? And when we ask this from this perspective, that education becomes a very important tool. Because we are studying, like you studied medicine, I studied medicine, we study medicine from a very specific perspective, right? And so it's really about getting knowledge from all the perspectives, who is able to get treatment, and in what way, and in what quality, for how long, and how much does it cost, right? And so education, I can just say that like 5 times maybe. So it's really, when it comes to competency, structure competency, it's also about really knowledge, right? It's about intellectual competency, knowing who is able to access and who's not. And then after that level of Wissenskompetenz, as we say in Germany, we are really dealing with social, political, and affective competencies. That means also, for example, when we look at the art therapist in psychiatry who ask the question, should I stay or should I go? After the 4th, 5th supervision sessions, they are able to prioritize what their own effective needs are. And that means that they are not just learning to become resilient in a culture or in a structure which is not appreciating their work. They are able to look at their work and to determine for themselves what is relevant for me and what is not relevant for me. And so they are able to reflect on how to let go of, for example, trying to gain access to recognition from a physician because it's not going to come, right? And learning to appreciate actually seeing their work in a certain way, and at the same time, creating reflective spaces and also creating educative spaces by asking, and by also asking for investments from the clinical director, because you cannot make structural change without the leadership of an organization. So when it comes to structural changes, as you pose the question, how can we maintain, or how can we create structural changes from within the structure? It means leadership, leadership, leadership. Leadership has that access to investments, had access to resources. How are resources divided? And so you need the leadership on the board. But until you have leadership on the board, you need therapists who are empowered enough to be able to focus on the effectivity of their work and not just to complain. And so sometimes in supervision, the first sessions, as I say, is really about bringing them to that space where it's not about complaining, but actually about seeing the strengths in their working space and being able to hold that space as a space of work a space of core work and a space also of actually improving their own effectivity. And then in a second, third level, going into dialogue and actually asking for education tools, supervision tools, and leadership change. It's really change management.
Thank you. Sabine.
Thank you so much, Lou, for that question. I think there's still a big deficit orientation in medicine, and I hope that you learn a lot about resource orientation and how to use the resources and the strengths of the patients and the other groups that you work with, and how to actually create self-efficacy in your patients. So hopefully that is taking place, and hopefully that carries over into when you then start in the medical institutions, because that's also another thing, you know, there's the educational space of medical studies where you have a lot of possibilities to think free, but then if you come into a medical institution, it might be quite differently. So please carry these thoughts over and involve your leadership, as Amma said, in order to drive the medical system away from a deficit orientation and more into a resource orientation. That would be a very important point, I think. And then just really listen to yourself, because you have the good ideas. Listen to your patients, postpone meaning making, provide a space where you really listen, and also to the other professional groups that you work with. I think, yeah, that's what I would love to see in the medical education more.
There's some very deep advice from both of you. I like also the repetition of education, 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 leadership, 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 and listen, listen, listen. But now to maybe a next question from the audience. Thank you for this question. Who dares to go next?
Here in the room?
Okay.
I repeat this question. We talked about different ways of healing in medical settings and forms of therapies, and also of knowing of disease. But is there a difference if you are in a clinical setting, but not on your own will? Let's say you are eingewiesen. Now I'm lacking the English term. Who can help me out?
Dependent on.
Let's say if you're
enforced treatment.
If you're enforced treatment or forced in the clinic, is there a difference in the setup?
Yes, thank you. That's such a beautiful question, because this is where we see how the history of psychiatry plays a very important role in how we perceive psychiatry and psychiatric settings. And so I'll start from the second part of the question, where you ask if there's a difference under forced treatment. Yes, there is a difference under forced treatment, because in Germany, according to law, you can only come under forced treatment in two situations. The first, you are a danger to yourself, to your life, and the second, you are a danger to others. So in that situation, it's an acute, dangerous situation. And in modern psychiatry, we understand the situation as just a phase. And so under forced treatment, where you are a danger to yourself and you are a danger to others, it is a very critical, acute, and short-term intervention. And this is how it is also thought to be by law and also by psychiatric practice, right? And so the main focus under force treatment is actually to create a space of dialogue, of understanding, so that the person under force treatment can, by their free will, hopefully choose to go on a healing journey. And at the same time, I also want to recognize that this is not always possible, right? Because of, like I said, spaces, time, fast track interventions in the clinical setting. So sometimes it's not possible to create this alliance, you know, between therapeutic team and the patient so that this intervention goes on for weeks. This is not how it's supposed to be. And so even under forced treatment, patients can choose which kind of treatment settings they want to enter, right? I mean, they always get sociotherapy, they always get movement therapy, there's always the medication therapy. So there are certain treatments that they can choose from, but they would not be able to choose from, for example, horse riding, swimming, any kind of therapeutic setting which involves them leaving that safe space, right? It's the space is constructed to bring them safety so that they do not harm themselves. But as I said, the goal is actually so as quick as possible to get them out of this forced setting into a setting where they can choose. And so to the first part of the session, yes, to be able to choose means I know what I can choose from. And this is where education plays also such a major role. Health literacy is really very, very, very relevant, because if I do not know that there are different possibilities, then I am not able to choose from those possibilities, right? So education, education, education.
Education. Anything to add, Sabine?
Yeah, this happens often in cases where eating disorders or, psychosis or bipolar phase is happening, like, yeah, and then, the people need to first get away from being a danger to themselves or to others, right? So we have some medical treatments first, most of the cases, and then once they are stabilized, yeah, it's a good question. Are they able to embark on this healing journey, or are they not able to at that point? But yeah, we try to offer different possibilities they can choose from. And of course, maybe some of them don't want to talk and say, I don't want to talk to anybody, but maybe they like to actually engage with one of the arts and can actually use a nonverbal space if the space feels safe to them, which we of course all try to facilitate. So yes, there are, it's different, and it's more difficult to establish a therapeutic relationship, definitely, but it's possible.
Thank you, Amma and Sabine, for the answers. And maybe a final questions from you guys in the room or online to Amma and Sabine. I mean, if there's not another one coming,
I mean,
is there?
I would also add one.
Wonderful, please.
Yes. No, that's it. Yeah.
That's we're entering meta level here now. So thank you for this question. I'll repeat. It's kind of a devil's advocate question, addressing that we spoke a lot on the importance of focusing on the patient, on the subjective, on the individual. But and maybe speaking of, it comes along with the first question that we have of like the shortcomings or the limitations of the system, or what is kind of wrong, or that there's so much wrong also in medicine. But what is the best criticism was the question of this kind of more, let's say, open-minded or holistic or psychodynamic perspective, and what would be your answer to it? So we're entering meta level.
Yeah, let me just say one thing. I often hear from people in the medical system that they say arts therapies are just a add-on, a nice to have. It's great what you guys do, but it's, and this is the criticism that I hear for arts therapies. So it's nice to have, but it's not, necessary, and does it really do anything? So just that. But, I mean, there's so much evidence that we now have. We have this big WHO report with more than 2,000 studies entering that the arts are really useful for. They have lots of benefits on well-being and health. They're very specific in a way, so the interventions can be geared to the problems that we meet. And there's primary studies that are on a very good quality level. And there's also a lot of reviews that we get recently that look into particular types of outcomes. And that's just, good to know for people in the medical system, I guess. So I'm not really making a point against the arts therapies, but I'm just giving you an argument that we often hear.
This kind of fits, Amma, leading to now. Very beginning, you said it before, should I stay or should I go? The role or the supervision that you have with art therapists or dance therapists that are feel kind of underappreciated, or kind of feeling like, okay, I'm a nice to have here. Yeah, so what's your take?
Yes, thank you so much for this question. And I would be more compassionate to myself and would not call it a devil's advocate. So that's an invitation, because this is a very important and relevant question to look at, And on the one side, looking at it from the evolution perspective, as humans, we are not an entity. We are a process, right? And so we are always going to be in that space where we question ourselves. And question ourselves does not have to be critique. Sometimes I think the word critique is a bit too harsh, but also to give ourselves feedback. How are we doing right now? How did we do in the past? Where do we want to go? So I think this is part of evolution, and that it is very helpful for us as humans to give ourselves feedback and to be compassionate while giving ourselves feedback, not to go too much into praise or to go too much into critique, but to be really real with ourselves in the sense of being authentic and looking at our truth. So from that perspective, I would say, I look at small babies, when I think about small babies from a neurological perspective and how they develop into adults. And I see that before the child starts to walk, they dance. And before the child starts to speak, they sing. And they are very poetic about that singing. And so for me, it's also a matter of really looking at our humanity and seeing that the arts, creativity is part of our humanity, and it's part of our energetic aliveness, the way we expand, also the way we experience ourselves and the way we experience each other, right? And so for me, I would look at more Antonovsky, who says that maybe it's not really about looking at pathology. So to come back to medicine, right, how we practice it, maybe it would be very helpful to look at how we heal and how we remain healthy. And the arts, definitely, I would not like to let go of that. as a psychiatrist, right? Because it's not only about that moment of intervention, it's also about that moment of just remaining healthy and understanding that there are some practices, there are some tools, there are some communicative ways, there are some ways of beingness as a human, which actually helps me to be healthy and to remain healthy and to become maybe even healthier, right? And so I would not really look at it as critique or praise or, right? I look at it, it's evolution of humans, and the arts definitely are part of humanity, and they are useful for our health and our well-being. So maybe it was a bit too philosophical.
No, I think that's kind of actually a perfect closing statement. I don't know, Sabine, if you want to add something, but this was an incredible praise of what we're doing here. Sabine, do you want to add something, or do we keep it at this?
I think we should just keep it there, Amma.
I think so too. Amma, you nailed it. You nailed it there. Thank you so much for this extremely inspiring discourse with the two of you. I took so many notes. I really learned in this conversation with the two of you, and I felt the compassionate and intellectual energy in our virtual room here. So it even works if we're not in the same room, in the same place. So thank you so much for that. I'm really taking with me home now your quote, Amma, we are not an entity, we are a process. And you, Sabine, speaking of to postpone meaning making, because that's when we start to learn. These are really deep thoughts and deep advices. So thank you so much for being with us, joining us, kind of pushing our encounters between art and medicine a step further. Thank you, the audience live in Berlin and you guys online, for being with us. Thank you for the questions.
So
And
let's have a concert of virtual and real applause then.
Thank you. Beautiful. I wish you all a wonderful evening, a great start into the week. Stay well, and I hope to see you all in 2 weeks again for our, I believe now, final session of the Healing Arts. Thanks again for this beautiful conversation. Sabine, Amma.
Thank you for the invitation, Lukas. A pleasure and an honor.
Thanks very much.
Thank you.
Thank you.
Thank you for me too as well.
Thank you, guys. Take care.